All right, good morning. My name is Russell Palm, and I'm an assistant member in GI radiation oncology, and I'm a radiation oncologist. So I use ionizing radiation to treat cancers of the gastrointestinal tract, everything from the esophagus to the anal canal and the rectum. But we also sometimes treat gastroesophageal junction tumors as well as gastric cancer. And what I'd like to do is just kind of preface and just spend a couple of minutes describing radiation, because I assume everybody's seen Oppenheimer and is familiar with nuclear radiation. But when a nuclear device explodes, there's heavy ions, alpha particles, beta particles, which are electrons, but also gamma rays that are released at high energy and can be highly damaging to the human body. Gamma rays are just photons, which is light. And we use light in CT scans that pass through your body to develop images. And what we do in radiation oncology is also use photons. You don't see, smell, taste, or feel radiation, but it passes through your body, and we're able with millimeter accuracy to design radiation treatment plans to treat certain parts of the body, minimize radiation dose to other parts of the body, but to try to effectively treat the cancer. So what you'll see here is two radiation treatment plans. On the left is a 3D conformal radiation treatment plan, which mostly uses opposed beams to cover a certain area. And this is an older radiation technique, which we still commonly use today in certain situations. And on the right is intensity modulated radiation therapy, which in certain circumstances can be an arc rotating around the patient, but using multiple angles. And to a certain extent, you can see a slightly more conformal high dose radiation field seen in red here, covering part of the stomach, which is not nearly as conformal on the left on the 3D radiation plan. But there's limitations in the use of radiation in the treatment of gastric cancer. One is the dose of radiation that we need to treat cancer is often quite high. And this is a tolerance limit of the stomach, which can only handle a certain amount of radiation before we cause very serious side effects. Additionally, the stomach is a mobile organ, and so it can distend and contract while you're eating. It also moves when you breathe. And so that's, to a certain extent, makes the treatment very challenging and technically difficult, where we often need to use wider margins and a bigger radiation field to treat a little larger of an area around the stomach. And then finally, I think maybe the primary limitation in the treatment of gastric cancer with radiation is it tends to be quite toxic, is that the stomach is a very emetogenic organ, which means it can be very nauseous, make patients very nauseous. Long term, there can also be malabsorption, where patients' diet is affected and their nutritional status is affected. And in certain circumstances, there can be increased toxicity after surgery, or even done before surgery if that's indicated. Just historically, taking a look back, and this is now an ancient trial from 2001, titled by McDonald, published in the New England Journal of Medicine, is gastric cancer has always been a surgically managed disease. And we look to identify if some patients may benefit from giving chemotherapy and radiation after surgery. And in this trial, after a very limited surgery, and as Dr. Pimiento previously mentioned, limited attention to the lymph nodes, there may have been some patients that benefited from chemoradiation when surgery is done in a limited manner. But this has been recently updated, and when chemoradiation is compared to just chemotherapy, and specifically multi-agent chemotherapy, when the surgeon is able to do a more expansive lymph node dissection, there actually is not a benefit to giving chemoradiation for these patients, even with node-positive disease. And so really, this has fallen out of favor, especially in the adjuvant setting, when that toxicity from radiation is even higher. Now, with positive results from the FLOT4 study, the standard of care is perioperative chemotherapy for most patients that are being treated definitively as surgery. And for the vast majority of patients, unless there's a positive margin, we don't offer radiation for these patients. The pros of this study was that there was a very high rate of margin negative resection. Many of the patients, or more than 90% of them, were able to proceed to surgery, and there was very low rates of chemotherapy toxicity. In the cons, what I'll see here, in beauty is in the eye of the beholder, and the PCR is a path complete response rate, which means when the pathologist looked at the cancer under the microscope after the surgery, there was no cancer left behind. And when I say beauty is in the eye of the beholder, it's actually, from a radiation oncology perspective, a path CR rate of 16% isn't that impressive, but you may talk to Dr. Mehta and Dr. Sheriff, it's actually, for a chemotherapy regimen, to have a path CR rate is actually quite impressive. And I think that's a baseline for medical oncology to continue to build on, and the viability of perioperative systemic therapy in the treatment. A detriment to offering adjuvant therapy is after a surgery in every disease site, there's limitations in patients being able to complete adjuvant therapy. And there's been a push more and more recently to give more preoperative treatment And I'll talk very briefly about preoperative radiation and its limited role. And so historically, we've progressed from doing a surgery first approach to sometimes chemotherapy and radiation to doing perioperative chemoradiation and surgery. And there's been some limited studies, and I'll talk about now, about using radiation prior to surgery to improve operability. And the rationale behind this is extrapolated mostly from esophageal cancer and application to gastric cancer, which is based on the cross trial, which I won't discuss today. Sorry about that, was sequenced. And so this was a small phase 2 study titled ROTOG 9904, which was published almost 20 years ago as well, that was looking to apply neoadjuvant chemoradiation before surgery. So in contrast to the previous study that I had mentioned where they gave it after surgery, we're now giving radiation before surgery on this trial. And importantly, this was not a randomized study. So they were just looking at a cohort and reporting the experience, but they also reported a very high margin negative resection rate, which is also a testament to the surgeons, but about a 10% improvement in the pathologic complete response rate when a local therapy such as radiation is added to the chemotherapy. And when we test the biology of the cancer with chemotherapy and radiation, that path complete response rate was associated with an improvement in overall survival at 1 year. Again, a detriment to using the strategy in radiation and gastric cancer is that high toxicity is often quite common, and 1 in 5 patients had a grade 4 toxicity on this experience, and this was not a randomized trial. There may be some situations when patients can't have surgery, and this is a multidisciplinary discussion with your surgeon. Sometimes there's cardiac comorbidities, and sometimes technically the surgery cannot be performed. But when radiation is given alone without chemotherapy, it's deemed palliative because there's no long-term survivors on randomized trials where we've delivered radiation without chemotherapy. However, as I mentioned before, chemoradiation may result in a path complete response rate of about 20 to 30%, but we don't know which patients derive that benefit and which patients may become long-term survivors. So this was a retrospective study, and that's what we have to lean on when there's limited experience from MD Anderson, which as a large cancer center, they see a lot of patients with rare cancers like gastric cancer. And it's important to look at the patients that were treated on this experience from 1996 to 2016. And on the right, what you'll see are mostly they were advanced stage cancers, with over 2/3 of the patients having T3 disease and most of the patients being lymph node positive. And then finally, about 80% of the patients had either chemoradiation or induction chemotherapy followed by chemoradiation, which is what we probably do most commonly here at Moffitt. Interestingly, they did perform restaging endoscopy on 50 patients of the 71 that they treated, and about almost half of those patients had a clinical complete response. Unfortunately, though, which may be a testament to the median age of the patients at 73, you'll see the 2-year survival approximated about 50%. So while this was an older patient population, the overall survival is still quite limited for patients that are treated with this approach. But I think what it does show is that there can be some durable local control for some patients that are ineligible for surgery or that refuse surgery. But standard of care, even based on this experience, still is a plan for perioperative chemotherapy and surgery. But there are some future advances in radiation oncology I'd just like to highlight for you guys today. One is a technology we currently have offering at Moffitt, which is MRI guided radiation. And what you can see here is an MRI scan of a patient on the table. And with an MRI, you actually have much more fine delineation of soft tissue. And so what this allows us is potentially the ability to just treat a wall of the stomach instead of the entire stomach. Of what we saw previously is now we can be much more focused on the radiation, which may allow us to deliver a little bit higher radiation dose and spare more normal tissue nearby. Secondly, in the future, at Moffitt, we are invested in particle therapy, and we'll have proton therapy. And a benefit of proton therapy is that there can be a much steeper dose fall off, which can spare normal organs here, such as the liver or the heart. And this is in comparison to intensity modulated radiation, which I previously showed. This is just showing the dose of radiation that goes across the body. For my opinion, I'm actually more interested in the MRI adapted radiation techniques, and I think there will be some utility for proton therapy here at Moffitt in the future. And finally, there is a role of radiation in palliating patients with gastric cancer. Very commonly, this is for pain or bleeding, and this can be a single treatment that's delivered or 3 to 5 treatments that are given over 1 week. I think actually that the bleeding maybe is a little overestimated on this slide from the studies that we referenced, but probably more to 60 to 70% in control of bleeding. And if it's a brisk bleed, we more frequently consult an interventional radiology team because they can frequently embolize a blood vessel. As Dr. Mock had mentioned, if there's a structural abnormality, a stent can be more effective for gastric outlet obstruction. But if there's pain, this radiation can frequently be applied for pain to the stomach or to other parts of the body. Thank you, guys.